Oh, it's a fantastic question. It is slide number 113. Yeah. This chapter is ultimately separated into three sections. The first section is what we did before the first exam. The second section is what we're doing in lab. This is section number 3. All right. So today's agenda is pretty simple. We're going to do joints, which is not the most stimulating of all topics, but it's one that's near and dear to my heart. This will be the first piece of material that is on the second lecture exam. The second lecture exam. So this from this slide forward, we're now talking second lecture exam. Like I just said, in case you weren't paying attention, the first section of this chapter, we did that in the first lecture exam. So we won't see that again until the final. The second section is what we're doing in lab, the naming of all the bones, and by and large, I don't really ask a lot of questions because they do that plenty in lab. And this is the third section of the skeletal system. When we think about joints, joints are ultimately, otherwise known as articulations. Articulations are where two or more bones come together and give flexibility to our skeleton. You've obviously all heard of joints. If you haven't, when how you been? And our joints ultimately help us to hold our skeleton together, since our skeleton's made up of those 206 bones that have to be somehow linked to one another. But more importantly, like I just said, they give our skeleton mobility. They give us the ability to bend and move our skeleton in all the various motions that we perform. And we classify joints in one of two ways. We classify them the easy way, which is functionally, or we classify them the more difficult way, structurally. The one that I'm going to by far ask you more about is the structural classification of joints, which is the less exciting, but ultimately the better way to think of a joint. We think about joints functionally. We break joints down into three varieties. We talked about synarthrotic joints, amphiarthrotic joints, and diarthrotic joints. And simply put, the difference between these types of joints is the amount of motion that they provide us. A synarthrotic joint don't move at all. And the way I always remembered that when I was learning this was it's a sin to move. So these joints don't move at all. So what's an example of a joint? An area of the body where two bones meet together that doesn't create any motion whatsoever.
Your ribs.
Mm-hmm.
All of the
Sutures. Yeah, your skull's a great, don't get me wrong, the ribs do move subtly because that's how we breathe. But the sutures in your skull is a great example. Right? We just learned them a couple days ago. Our parietal bones aren't doing this all day long, right, to move around our brain. They stay nice and solid, no motion whatsoever. And that's the way we like it. We want it that way. You don't want those, trust me, you don't want those bones moving. Right? An amphiarthrotic joint is a joint which has slight amounts of motion. And by that, we're talking about motion that is measured in millimeters. We're talking millimeters of motion. So it will be a good example of an amphiarthrotic joint, a joint that just gives us a little bit of motion, but not a ton.
The one you just said, ribs?
Ribs is a good example. That's where ribs would definitely fall. Right, we're talking about just subtle amounts of motion, right? But they give us some good function. Then we have our diarthrotic joints. Diarthrotic joints are joints that are freely movable. And obviously this is when we think of a joint. If I was just to tell everybody here, name a joint, you'd have named elbows and shoulders and fingers and wrists and knees. Those are all really good examples of diarthrotic joints. Joints that have wide varieties of motion. And we're going to spend most of our time dealing with diarthrotic joints. Now, the more complex way to talk about joints is to talk about them structurally. Now we're talking about what's the physical makeup of those joints. And all of these three varieties of joints differ in how those joints are ultimately put together. We have fibrous joints, we have cartilaginous joints, and we have synovial joints. And the big difference between these three joints is the material that's found in between the bones. Fibrous joints, what's found in between those joints is fibrous connective tissue. So you have two bones that are connected to one another by some tough fibrous connective tissue. Cartilaginous joints, as their name implies, are joints that are separated from are bones that are separated from one another by cartilage. It's going to be either hyaline cartilage or fibrocartilage, depending upon the joint that we talk about. And then last but not least are our synovial joints. And synovial joints are separated from one another. These are bones that are separated from one another by a fluid called synovial fluid, hence the name of the joint. By and large, our fibrous joints are going to be generally immovable, and we're going to see examples of them here in a second. Cartilaginous joints are usually either immovable or give us some slight amphiarthrotic motions. And then last but not least, our synovial joints. These are going to be our freely movable joints, our knees, our hips, our elbows, our fingers, shoulders and wrists, things like that. And again, as you're learning this material at home, the emphasis I really want you to place is on synovial joints. The vast majority of the questions that I'm going to ask you are going to be on synovial joints. Regardless of what type of healthcare you go into, the majority of the joints that you're going to deal with in your healthcare lives are synovial joints. Nobody comes in to my office with a suture joint problem, right? They just don't. They come in with synovial joint problems, every now and again cartilaginous joint problems. So, let's take fibrous joints first. Fibrous joints, these are joints that are separated from one another. These are two bones that are connected to one another by some sort of fibrous connective tissue. And they come in three very important subcategories. So, sutures, syndesmoses, and gymphoses. These are varieties of fibrous joints. And fibrous joints are Toyotas. These are Camrys. I can't think of any other Toyotas at the moment. This is a Tundra. This is a Corolla. All right, there are varieties of fibrous joints. And these are all of these joints are found somewhere in the body, so it's going to be important that for me, you understand what a fibrous joint is. It's a joint that's it's two bones separated by fibrous tissue. Understand the varieties of them, and then be able to give me examples of each of these three. If you can do that, the test won't be so bad. The questions asked on the test won't be so bad. So, sutures. Where do we find sutures?
Skull.
In the skull, right? So we're thinking about the skull. All those bones we talked about on Tuesday, when we talked about the parietal bones and the frontal bone, the occipital bone, and the temporal bone, and we named 4 different sutures, right? We named the sagittal suture, the coronal suture, squamous suture, and the lambdoid suture. Each of those sutures are filled with fibrous connective tissue, turning that joint, those two bones and their suture into a joint.
I don't know if you answered this question, but what is thrombosis?
One more time? Synarthrosis? Synarthrosis, yeah. When we talk about synarthrosis, now you're talking about the
Like
functional classification of
Like
joints.
the ending.
Oh, arthrosis?
Yeah. 'Cause
Joint.
They
Arthrosis is joint.
joint.
Yeah. So arthrosis is joint. Amphi means a little bit. Syn means none. Di means freely. So diarthrosis is a freely moving joint. Amphiarthrosis is a joint that moves a little bit. Synarthrosis is a joint that doesn't move at all, where no motion occurs. So when we think about a suture joint, a good example of a suture joint is going to be our skull, where we see the separation between two of the bones in our skull. That joint, that crevice rather, is filled with fibrous connective tissue, making it a joint. A joint is two bones separated by some sort of soft tissue. In this particular case, we're talking about a suture. The bones that separate, the joints that separate the bones in our face are also suture joints. A syndesmoses. Sin means no motion, so now we're talking about a connection where there's no motion. The best example is found at the very, very end of our tibia and our fibula, which are the two bones of our lower leg. In a syndesmosis, what's happening is we have two bones. Here's our tibia. And here's the fibula next to it. And as we get to the end of this, where our foot ultimately is, we take connective tissue and we basically connect these two bones to one another. And in doing so, we create a joint. These two bones are held together. They don't give us a whole heck of a lot of motion. They give us a little bit of motion here and there as we move our foot. But by and large, this is still a pretty immobile joint. So when we think about the very, very end of our tibia and fibula with fibrous connective tissue overlaying and connecting these two bones to one another, this is also a joint. We call this a syndesmosis joint. This also occurs at the end of our radius and our ulna. Again, nothing sexy about that joint, but it's a joint nonetheless. The last of our fibrous joints is known as a gymphosis. There's only one example of a gymphosis, and that is in the bones of your face, specifically where the teeth, unfortunately I don't have a picture of this. When you think about a gymphosis joint, here's a tooth, and here's the skull, or the bone that it's sitting in. There's connective tissue called the periodontal ligament, which connects a tooth to the jaw. That's a joint. That joint is called a gymphosis joint, and it's also referred to as a peg and socket joint. And just to show you how academic all this is, my brother is a dentist, my older brother Chris is a dentist, and a very good dentist to boot. And I asked him what he thought of gymphosis joints just one day, just screwing around, and he said, "What's that?" I'm like, "It's what you do for a living." He goes, "I didn't know it was called a gymphosis joint." Doesn't stop him from being a fantastic dentist, all right? So we're talking very academic, I admit. But at the end of the day, the teeth as they sit in the mandible or the maxilla, connected to one another. These two bones, the bone of the tooth, the bone of the jaw, is connected to one another by a ligament called the periodontal ligament. We refer to this as a gymphosis joint. And this joint, for people who have taken what's the nursing test? The HESI? Is it the HESI test? For
Yes.
nurses?
Yes.
I've heard every now and again they throw gymphosis joint on the HESI test to pick a very oddball joint. Everybody good with fibrous joints? Good. Which brings us to cartilaginous joints. Now in cartilaginous joints, we still have two bones separated by soft tissue, but now as the name implies, the soft tissue that's separating these joints from one another is cartilage. So instead of fibrous connective tissue, what's separating these two bones from one another is cartilage. And that cartilage is either going to be hyaline cartilage or fibrocartilage. Of the two varieties, again, if this is Toyota, these are the varieties of Toyotas. One is called a synchondrosis, the other one is called a symphysis. In a synchondrosis, we have an immobile joint where two bones are separated from one another by cartilage. The cartilage of a synchondrosis will always be hyaline, always be hyaline. And the best example of a synchondrosis is going to be our growth plates. We talked about growth plates when we were talking about what particular part of the chapter? We were talking about long bones, right? We talked about how we had the diaphysis, which is the shaft. We had the epiphysis, which was the end, and then separating the epiphysis from the diaphysis was either the epiphyseal plate or the epiphyseal line, depending on if we were talking about a child's bone or an adult's bone, right? And I told you that when we take a look at the long bone of a child, that epiphyseal plate is made up of what material? Cartilage. And what type of cartilage was it? Hyaline. So what type of joint do we have right here? A synchondrosis, right? Because we have two bones. We have two bones separated by soft tissue, right? Is it a great joint? No. But is it a joint? Technically, yes. We call that a synchondrosis. So we think about the epiphyseal plates, the growth plates of kids' long bones. That's an example of a synchondrosis, which none of us in this room have anymore. We don't have that joint anymore, or at least we should.
You said the synchondrosis is always going to be hyaline?
Always. Always, 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 always hyaline cartilage. Another example of a synchondrosis joint would be our ribs. As our ribs come around and attach to the sternum, we're going to learn this today when we get into lab. The sternum, which is the bone here in the center of our chest, and the ribs are ultimately connected to one another by cartilage. There's cartilage that basically spans between my rib here and my sternum here, connecting these two bones to one another. It's also another example of a synchondrosis. Hyaline cartilage separating two bones from one another. The last of them is a symphysis joint. Now a symphysis joint, instead of having hyaline cartilage, a symphysis joint will always use fibrocartilage. And we talked about two parts of the body. When we were talking about tissues, I said there's two parts of the body where we have a really good example of fibrocartilage. Where were those two parts of the body? Discs. The discs of the spine was one. And what's the other one? Pubic symphysis, right? So we have the pubic symphysis and the discs of the spine. That's the places where we find fibrocartilage. Those are also the two best examples of where we find symphysis joints. Symphysis joints are joints where we connect two bones to one another with fibrocartilage. A little bit of motion, not a ton, so these are going to be amphiarthrotic joints. So again, to look at good examples, we think about connecting the sternum to the ribs. Good example of a synchondrosis, as is our growth plates. The intervertebral discs, where now instead of hyaline cartilage, this is fibrocartilage, as well as the pubic symphysis, which is what we see right here, connecting the left and right pelvic bones to one another. All good examples of cartilaginous joints. Extra picture, just for your viewing pleasure. Which brings us to the most important type of joint. And if you're gonna remember anything from what I talked about this morning, from this slide on is where you want to make sure you remember. Synovial joints are by far the most important joints of the body when it comes to function. In that these are what provide us with all the great motions of the skeleton. And when we think about synovial joints, synovial joints have a few very important commonalities to one another. First off, synovial joints are always separated by synovial fluid. So when you think about your knee, your elbow, your shoulder, your hip, your fingers, wrists, ankle, bones of the foot, all the bones involved in those joints are separated from one another by a fluid called synovial fluid. All synovial joints have what's known as articular cartilage. And articular cartilage is, there's cartilage that are covering the ends of the bone that are involved in that joint. They're not what separates the joint from one another, but they allow for the joint to be able to have its free range of motion without causing bone-on-bone contact. And this articular cartilage is always hyaline. Always. This fluid exists in a space which is called the synovial cavity. This is where the fluid resides. So the fluid sits within a cavity. When you think about your knee, right? Your knee are two bones that are not like this. Those bones are separated a little bit, and there's a space in between those bones. It's a cavity. That cavity is filled with fluid, and on the surface of the bones surrounding that cavity is cartilage called articular cartilage, which is always hyaline cartilage. In order to keep these bones together, all of these synovial joints have something called reinforcing ligaments. Suture joints, for example, don't need ligaments to keep their joints together because the fibrous connective tissue is doing it for us. But if you have two bones that aren't directly attached to one another, they're kind of floating by one another, there better be something to keep those two bones together, otherwise you're going to get dislocation and all that kind of fun stuff. So all of these synovial joints will have reinforcing ligaments. A couple other things that the chapter doesn't really talk about but are important to think about. All of our synovial joints have things called bursas. Everybody here has heard of bursitis, correct?
No.
You ever heard of bursitis? Lucky you. Bursitis sucks. Bursas are little fluid-filled pouches that are strategically placed in and around synovial joints, and the job of a bursa is to prevent friction from occurring within the joint. All synovial joints have some sort of bursa, either 1, 2, or 3 of them, or these little sheaths that are bursa related. And almost all, if not all, synovial joints have something referred to as fat pads. And these are exactly what they suggest. Fat pads are literally pads of fat, which again are strategically placed around that joint to help cushion and protect the joint. So as we take a look at the variety of synovial joints, we're talking about joints in our wrist and hand, our elbows, shoulders, and hips. And to kind of look at, yes ma'am?
I'm sorry, but on the third synovial cavity, you put fluid is,
That's where the fluid is.
oh.
Fluid is here.
Okay.
Yeah. So if you take a look at a traditional synovial joint, this picture shows pretty much all the key ingredients of a synovial joint. First off, we have two bones, your scapula, this is your shoulder by the way. So we have the scapula here and the humerus here making up our shoulder joint. These two bones are not connected to one another, they're floating by one another. So there's a space in between these two bones, and we see that space here in yellow. This is called the synovial space. The synovial space is ultimately lined on either end of the bones are lined with articular cartilage, always hyaline, which as that bone, those two bones do contact one another as we move, it doesn't create bone on bone. This space is filled with a fluid. That fluid is called synovial fluid. This joint has a series of reinforcing ligaments. We have one here, one up here, here's another. And these ligaments help to keep this joint together. Oh, one more that I forgot to put in here. All of these joints have capsules. This capsule ultimately helps to keep and maintain the synovial fluid. That synovial fluid just didn't show up out of nowhere, it's produced. And the capsule has specialized cells on the inside that produce and secrete that fluid therefore making sure this fluid is always maintained. And the fluid that's within this joint is kind of like oil to your car's engine. It lubricates, right? The reason why we put oil into our car's engine is to lubricate the different moving parts of our engine so that they don't have metal on metal. Well, the same thing with synovial fluid. It's the same basic premise, but for the joint. It helps to lubricate that joint to prevent this joint from having bone-on-bone contact, which always leads to friction and pain and discomfort and all kinds of dysfunction. So synovial fluid, articular cartilage, cavity, reinforcing ligaments, we got through bursa. As we take a look at this joint, if we look up here, there's a fluid-filled sac called a bursa, and the job of this bursa is to prevent friction from occurring in this joint. As we move this joint in all of its various ranges of motion, the one thing we don't want to have happen is friction occur in and around that joint. Because if I have two pieces of tissue rubbing on one another for a long enough period of time, what's that going to create? If I do this to my hands long enough, what happens to my palms? They get hot, right? Which on a cold day makes great sense to your hands, but if this happens in your joint, what does heat lead to? Well, down the road, but what about initially? If I do this long enough, what's going to happen to my skin?
Wear it down.
It's going to turn what color? Red. And red's a sign of what? Inflammation. And inflammation is never a good thing, right? Not in a joint. This bursa prevents that inflammation from occurring. In particular, where this one is located, it's going to prevent this bone and this bone from coming and rubbing into one another, which will ultimately cause inflammation. So these bursas, as we move our shoulder, they roll in order to prevent friction from occurring around the joint. Here's another variety of bursa. This is called the synovial sheath. And the synovial sheaths ultimately are designed to wrap around tendons that cross into this joint, preventing this tendon and this bone from rubbing on one another, again, causing friction, which causes inflammation, which will lead to dysfunction.
So when people get injections and they're like when their tissue or when cartilage wears out and they get injections in the knees, what exactly is that replacement?
It depends on the injection you're talking about. Injections come in a varieties of, there's a variety of injections. So the most common of all the injections are steroid injections. And a steroid is really designed to create a reduction of inflammation. So people who get steroid injections into their shoulder, for example, what's happening is somewhere in this joint we have inflammation, whether it's a ligament inflamed, a muscle inflamed, a tendon inflamed. There's inflammation. And so what the injection's trying to do is reduce that inflammation, right? So that we can regain range of motion, reduce pain, and then ultimately get that patient to rehab. On the same token, there's also gel injections. You hear about these in the knees all the time.
Yeah,
That's
Like
the
this,
one I
the
was
Syndesk, right? Which are great, they're fine. It's an artificial fluid, it's a synthetic fluid,
it's temporary.
very much so. But here's the thing,
Should have replacement.
see, people talk about temporary as a bad thing. Temporary, the fluids they put into people's knees now, they're supposed to be temporary. It's a, hey, we're just trying to get you some damn relief, chill out. If you can get a year out of that, if I told you right now you have horrible knee pain, I can get you pain-free or virtually pain-free for a year, and then you'll have to have another one, which is as simple as a little injection in your knee, and you're 78 years old, wouldn't you take it? I would take it every day of the week, twice on Sundays.
No, my grandma decided to go walking through Manhattan, like,
Yeah. So, yeah, it's a synthetic material. It's basically a gel that basically takes the place of the synovial fluid, therefore buffering the space between the two bones. What happens when people get that Syndesk is they have usually bone on bone in the knee, so they put a fluid in there that's really thick and viscous, which ultimately takes the place of the synovial fluid and prevents that joint from rubbing wrong on itself. It's usually for people with really bad arthritis because they've worn away the articular cartilage. And so it just gives them the relief. It doesn't last forever because the body eventually gets rid of it.
So they're able to inject the gel inside the membrane?
Inside the capsule.
Inside
Mhm.
the
Yeah, and then that fluid takes the place of the synovial fluid, or it adds to the synovial fluid to again, give that joint the buffer that it needs. The third type of injection that they do, and we do this in my office, is called a PRP injection. PRP injection is an injection where we remove your blood, we spin out all the blood cells, red blood cells, white blood cells, and platelets. We take your plasma and we inject your plasma into the joint. And by doing that, the plasma has within it factors that are protein-based that help to reduce inflammation. The third type of injection that you can do, we do this one in my office as well, it's called a stem cell injection. In a stem cell injection, what we do is we remove your stem cells from your pelvis. We actually put a needle into your pelvis. We remove your stem cells, right? We spin those and we inject the stem cells into the joint. And a stem cell is a cell that the body can turn into any cell it needs it to be. So if you have torn up cartilage and torn up ligaments and torn up capsules in your shoulder, and I inject stem cells from your body into your shoulder, your body will turn those stem cells into ligaments and tendons and articular cartilage and rebuild the cartilage, right? So it's a stem cell injection. So the question you have, which is a very valid one, it doesn't have a simple answer, because the answer really depends on what are you injecting. And which one you would do really depends upon, obviously, the patient's want.
Yeah, well, I was thinking about the gel one.
Yeah.
Where it would go.
You know, yeah. The gels are, if somebody comes into my office, they got a botched up knee, right? And I tell them, hey, look, here are your options. You have an option of a complete knee replacement. You have the option of living with it, of course. You have the option of rehab. You have the option of pain management, right? You have all these different options on how you can treat the knee, right? We tend to believe there's one option.
And
Or
the
there's
stem
only-
cell one fixes it forever, right?
Well, that's been around long enough for us to be able to tell you that. And nothing's gonna last forever. Because at the end of the day, even if you fix that tissue, you're still walking on it, you're still just, you're still beating that knee up, right? But here's the thing, you come into me and you've had a surgeon who's told you you need a complete knee replacement. How old are you?
About 26.
26. So you're gonna get 15 years out of that complete knee replacement. So 26, when you're in your early 40s, you're gonna have to replace that knee. Then when you replace it in your 40s, you're gonna have till maybe 60, then you're gonna have to replace it again. And then if you live into your 80s, you're gonna have to replace it a third time. So if you go knee replacement at 26, what you're basically saying is, I'm gonna do this knee surgery at least twice more as long as you live the normal lifespan, right? So most people are gonna say, you know what, I don't wanna do that. If I'm gonna do a knee replacement, let's do it once, which personally is why I would go two. So if we wanna try to avoid the knee replacement but still get you out of pain, now we got some options. We gotta talk which one makes the most sense. Which one you go with should be based primarily around what damage you have. I mean, if what you have is cartilage damage and what you're having is bone on bone, the syn disc is gonna give that synthetic synovial fluid injection is gonna give you about a year. And after that, it's gonna go away and you're gonna have another one. Which again, like I said, if that's the worst thing you do to your body, you're golden. You're golden. But do you wanna do that every year? So the stem cell injections are gonna offer you, while the syn disc doesn't do anything to fix the joint, nor is it designed to, right? It's not advertised to. But it's really a buffer. The stem cell injections actually offer you the ability to fix the knee, to actually replenish some of those damaged tissues and make that knee better than it was. But they're also more expensive. To do this stem cell injection, it's gonna cost you $3,000. And it's all out of pocket, because insurance doesn't pay for it. To do the synthetic injections, it's gonna cost you maybe a couple $100, depending on your insurance and how much, you have an 80-20 or whatever, what your plan is. So there's a lot of factors that go into it. So, for what it's worth. Now, when we think about our synovial joints are ultimately broken down into 6 categories, or 6 subcategories. So again, if synovial joints are the Toyota, each of these are the varieties of Toyotas. the Camrys, the Corollas, the Tundras, the what have yous. And each of these joints are very unique to a very specific function, right? They're separated by their function. And as such, they're separated by where we find them in the body and the amount of motions they provide us. So, when we think about a plane joint, so the first type of synovial joint is a plane joint. And a plane joint is a joint where you have two bones that move past one another in indiscriminate motions. And we call this gliding. And in some textbooks, you will hear this referred to as a gliding joint. So what's happening here is you have two bones. Each of my fists represents a bone. These bones are basically just gliding past one another. Very indiscriminately, no specific pattern per se, based on whatever the body's trying to accomplish. And there's two very good examples of where we find gliding joints. Area number one is the bones of the wrist, otherwise known as our carpal bones. And the second one are the bones of our foot, and we call these the tarsal bones. So when we think about the bones of our wrist, we have 8 little bones making up our wrist, and these bones, as we move our hand and wrist in all the various directions we do, we accomplish this in part because the bones of our wrist just indiscriminately kind of glide past one another. We refer to this as a plane joint. The second type of joint is called the hinge joint. When we think of the word hinge, what should we think of first? Get away from the body. If someone out in the street said, "Hey, what do you think about hinges?" What is the first thing you're thinking of in your mind?
Like the thing that keeps the door together. Like
Doors, right? Doors have hinges, right? And what do doors do? They open and close. Hinge joints do one thing, they open and close. This is all they do, right? They create one simple plane of motion. They open and close, and we don't call this opening and closing, we call this flexion and extension. That's all these joints do. And they always work in the sagittal plane. So when you think about joints, there's 3 that should come to mind. I'm giving away, obviously, the elbow is one. The knee would be another, right? Because all it does is open and close. What would be a good example of a third hinge joint? It's a great guess. It's not correct, but it's a great guess.
Neck?
Nope, because I can go side to side, I can rotate, I can do all kinds of great motions in my neck. My fingers, right? The fingers are your other ones. All you can do with your fingers are flex and extend them, right? So when you think about the joints that exist between the bones in your fingers, these are also hinge joints. So hinge joints, your elbow is a hinge joint, your knee is a hinge joint. All they do is flex and extend. Because if you do anything other than flexion and extension with these joints, you've just damaged that joint, which is no bueno. So when we think about these joints, we're thinking about the elbow, we're thinking about our knee, and we're thinking about our fingers. Hands down the best 3 examples of hinge joints. The next one is the pivot joint. If I say the word pivot, what word should come to mind? Think basketball. If I pivot in basketball, what am I doing?
You're turning.
I'm rotating. So these are joints where all they do is rotate. These are joints where all they do is rotate. And there's two very good examples of where we find them. So I'll tell you where they are and then I'll explain what I mean. So C1 and C2, we're about to talk about the spine in lab today. The very first two vertebrae of the spine are called C1 and C2. And those two joints fit together in a way where all those two bones are allowed to do is this motion. In fact, 80% of the reason why we can turn our head left and right is because of the first two vertebrae in our neck. And they are a quintessential example of a pivot joint. Proximal radius and ulna. Radius and ulna are the bones in our forearm. Proximal means, am I talking about this side or am I talking about this side?
Upper side,
The elbow side or the hand side?
elbow.
Talk about the elbow side. So where the radius and the ulna meet in the elbow is called the proximal radial ulnar joint. And they permit us to do this motion. All right, allow us, we call this pronation and supination. This is the only motion that that joint allows for us to do. It's rotation only, right? One bone's rotating over the other. So these are two very good examples of pivot joints.
What's the name of that one?
Pivot. Oh, the name of that joint?
Yeah.
The proximal radial ulnar joint. But if you just put proximal radius and ulna, you're in like flow. Condylar. These are joints that are permitting two different motions. One of them is flexion and extension, which is what we see here, right? Flexion and extension, we saw with the elbow. The other motion that these joints allow for is something called abduction and adduction, which is this motion, right? So there's a few joints in the body where we can flex and extend them and abduct them and adduct them. Our knuckles are a really good example. Everybody here know, does everybody here remember who Dikembe Mutombo is? Shame on you if you don't know who he is. He was the Rockets center for a bunch of years, right? He was a really good basketball player. And when he would swat the ball away from somebody, what did he do?
Block it.
Well, after he blocked it, what would he do? That was kind of his calling card.
You like yell or something. Oh.
He would do this, right? It became known as, I think, the Dikembe finger wag or something like that, right? This motion is abduction and adduction. And then I can also do this with that same joint. So I have two different ranges of motion with that one joint. That's a condylar joint. My wrist, I can flex and extend it, and I can abduct it and adduct it. That's a condylar joint. My foot, I can move it up and down like I'm going on and off a gas pedal, but I can also come in and out with it. Condylar joint. Everybody with me?
So wouldn't your neck be the same?
Sorry, I didn't quite catch that. Could you please?
Would the neck be the same? No, because I can do this. Now, each individual, so when you're thinking about, you gotta remember, these two motions are the only motions that these joints do. Last two. The next one's called the saddle joint. Saddle joint is only found in one spot, and that is your thumb. And it gives us a very unique range of motion. Yes, ma'am.
For the condylar, you said it's found in the wrist and the fingers?
Wrist, knuckle,
Wrist
and ankle are your three best examples of a condylar joint.
Thank you.
Saddle joint. It's a very unique joint that's only found in our thumb. Our thumb permits us to do a very unique range of motion. And we always hear about how what separates us from the animal kingdom is that we have what type of thumbs? Opposable thumbs. What does it mean to have opposable thumbs? Hmm? Well, it means that I can take my thumb and I could touch the pads of all 4 of my other fingers. The animal kingdom can't do this, but we can. This is known as having an opposable thumb. I can take my thumb and move it in this direction. This motion is called opposition. So the movement that the saddle joint provides us is the movement of opposition, which means that I can take my thumb and touch the pads of my other 4 fingers. It's what separates us from the animal kingdom. So when you hear about us having opposable thumbs, that's what they're talking about. So the only place where you find a saddle joint is in the thumb.
So what does it mean when people are double jointed in their thumbs?
That means that the joint, those people have joints that are more lax than they ought to be. So as a result, the range of motion that those individual joints provides them is greater than what it should be. Being double jointed is not a positive thing. It's a hyperflexibility. People who are double jointed, it might look cool when they can do all these different bendings and whatnot, but I promise you those people are gonna have joint problems much sooner than folks with normal joint range of motion will. Yeah. And then last but not least is the easiest of all the joints. This is our ball and socket joint. Ball and socket joints provide us with the ability to flex and extend, to abduct and adduct, as well as to rotate. So these are joints that give us the greatest ranges of motion. There are 2 places where we have ball and socket joints. They would be the what and the what?
Shoulder.
Shoulder is definitely one. What would be the other? Our hip. Shoulder and hip are the 2 best are the 2 only examples of a ball and socket joint, where you literally have the head of some bone that looks like a ball, and then a socket of another bone, and they fit into one another just like so. Our shoulder and hip both work this way. When we think about our shoulder, I can flex and extend my shoulder. I can abduct and adduct my shoulder, and I can also rotate my shoulder. So I have 3 different ranges of motion within this one joint. We refer to this as a ball and socket joint. Everybody kosher with that?
Out of all these joints, which one is the most common in your body?
Synovial. Of all the different, are you talking about of all the different types of synovial joints, or all the joints that we've talked about?
All the different types of synovial.
Of all, it's a good question. I'm gonna say it's not pivot, it's not saddle, it's not ball and socket. There's a whole bunch of plane joints because we have 8 carpal bones and 7 tarsal bones. That creates a lot of different joint surfaces. There's a lot of condylar joints. I'm gonna say it's either gonna say it's a plane joint or I'm either gonna say plane or hinge, because you have a bunch of different little hinge joints in the hands. But I don't know, I've never thought about that question that hard before. Everybody kosher with the joint types? Good. Now, when we talk about the one thing, I don't know if it was this class or the last class, we talked about the difference between the fetal skull and how we have soft spots. When we think about the fetal skull is a little different than the adult skull, and obviously the bones haven't been completely created yet, and so as a result, in the fetal skull we have something known as soft spots, and these soft spots are ultimately called fontanelles. These soft spots give a fetal skull the ability for the brain to continue to grow, and the skull's gonna continue to grow as that baby's going through their first couple years of life. Usually by age 2, our skulls have completely fused to one another and created all those sutures. But until such a time, because these bones haven't fully developed, what we have are a series of soft spots. Here's the frontal bone, parietal bones, occipital bone. And we create a series of soft spots, anterior fontanelle, posterior fontanelle. This is the main soft spot that most mamas tend to not want you to touch because it's the biggest of them all. And as we look at fetal skull from the side, there's a couple other soft spots. Mastoid fontanelle, the sphenoidal fontanelle. These again are just soft spots. These are spaces between these bones of the skull that we learned on Tuesday that are going to allow for the brain to continue to grow, because the brain continues to grow for the first couple years, and then ultimately allow these bones to continue to get bigger till they ultimately, just like tectonic plates, kind of meet and bump into one another and create these suture joints. Kind of looks like a turtle, doesn't it?
It's so funny.
Yeah.
Fetal skulls are fun.
It's amazing that something so cute can have such an ugly skull. Or alien-looking skull, at least. Some of the changes that happens to the body, to our skeleton. Babies, when they're born, their head's bigger than their bodies, right? They're kind of like reverse Weeble Wobbles, which is why they just can't keep that bad boy up, right? It's heavier than their muscles allow for it, right? So ultimately, babies are born with big heads, right? My 13-year-old's head was enormous. I'm like, dude, that is freaking outlandishly big, right? He was 10 pounds, and he was all head.
Oh, he's a big one.
Yeah, well, all of our babies were big, 9, 3, and above, all 4 of them. But then what ends up happening, their skull and their brain grow slower than the rest of their body does, and they ultimately catch up, thankfully, right? During puberty, some changes when we have the next big change. The first couple years of life, yeah, obviously the skeleton and the body's catching up. Then at puberty is when we start to see some big changes. The big change that we see in the female skeleton is that we start to see the pelvic broaden, and that quote-unquote hourglass type shape starts to occur. Obviously, as that pelvis broadens, that's going to allow for women who are now, as you go through puberty, you now become, you then have the ability to give birth to kids, and you need that wider pelvis for that to occur. Men, on the other hand, our entire skeleton becomes bigger, which is why we get broader shoulders, bigger in size, bigger in weight. We just have a little more robust, that's the job of testosterone. By the end of adolescence, the epiphyseal plates become fully ossified. Now for ladies, anywhere from 17 to 19 is when your epiphyseal plates tend to completely end. For the gentlemen, it can be as late as 25, but usually it's closer to 20, 21. We just do everything after you. Ladies, you do everything first. You go through your growth spurts first, which is why if you go to a 4th and 5th grade class, the girls are this tall, the boys are this tall, right? And then boys catch up and surpass as you go from the end of middle school into high school. We just do everything late. Some of the diseases. The big one, when you think about the skeleton or the skeletal system, is osteoporosis. Osteoporosis is a bone thinning disease, where what's happening is the amount of bone that you are taking away because of osteoclasts is greater than the amount of bone you're putting back into the bone via osteoblasts. So as a result, think of the bone as a savings account. If you put money into a savings account, you get richer, right? As you take money out of your savings account, you get poorer. Well, if you take out more money from your bank account than you put in, you're eventually going to be what? You're going to be broke. And if you're broke, you have osteoporosis. So in osteoporosis, you have taken more calcium out of the bone than you've put calcium back into the bone. And as a result, you go bankrupt. And when that happens and you have osteoporosis, your bones have a greater ability for damage. Specifically, they become more fragile and fractures become much more frequent. By far, it happens more to women than it does to men. Typically, 65 and above is when you start to have to worry about it. When it does happen to men, it's more severe. The test that you use to see if you're if you have this issue is a bone density exam. And the bone density exam, they measure how dense your bones are. And as long as your bones are of a certain density and above, depending upon your age frame, you are good to go. If not, then they're gonna have to start treating you for osteoporosis or what's known as osteopenia. Osteopenia is the suggestion of osteoporosis. It's kind of like pre-osteoporosis. Another way that osteoporosis can be diagnosed is by taking an x-ray. You know, somebody comes in to a chiropractor, for example, we take an x-ray to see if there's damage to the spine, and we see that the bones are thinner than they ought to be. That's known as osteopenia as well. Then we do bone density to see if it's actually osteoporosis. And what we're seeing here, this is the inside of the spongy bone of a normal bone where we can see the nice trabecular patterns, nice and robust. This is the same trabecular pattern, but of someone with osteoporosis. You can see how they're a lot smaller and thinner. They got a lot of little pock marks in them. This bone is not as strong as this bone.
What did it mean by estrogen aids in health? Normal cases?
This is a disease that is much more common in women. It's just much more common in women. And the one thing that happens to ladies as they get into their 50s is they go through what process?
Menopause.
Menopause. Menopause is ultimately the signal that a woman is done having children, right? Because they've run out of eggs. And so as a result, the ovaries, which produce the eggs, and the ovaries, which also produce their estrogen and progesterone, ultimately start to deplete. The ovaries are no longer as functional as they were during their childbearing years, middle school or early high school through 50. As a result of that, their estrogen production starts to drop. And unlike men, who we testosterone and testes all of our lives. When you're 90 years old, your testes are producing testosterone. When she's 90 years old, her ovaries are not producing estrogen. She's getting all of her estrogen from her adrenal glands. So because the women's body and their production of estrogen alters due to this one event that is very female, right? Men don't go through menopause. What happens is the estrogen, as it drops, it leads to it's one of the leading causes to them becoming osteoporotic. Meanwhile, if they can keep their estrogen levels normalized, their chance of hitting osteoporosis or having osteoporosis significantly decreases.
So if men's testosterone levels went down, then they would have osteoporosis?
No, not necessarily. And again, as our T drops, which tends to start in the 40s, mid 40s to 50, it doesn't have as drastic of an effect on our bone mass as it does ladies, for a couple reasons. One, we just spent 45 years producing bigger bones. So it's like if you save $1 million and she saves $20,000, you can lose more money before you go broke than she can lose before she does, right? You just spent 45 years building these big, strong bones. Now your testosterone levels drop. You've got more bone to deplete before you hit osteoporosis than she does. Does that make sense?
Yeah, that's lower rate.
Right. Furthermore, we produce testosterone 24/7 for the rest of our lives. Yeah, maybe our levels go down a little bit. They certainly do. But they don't go down as drastically and as sharply. Ours goes down at a steady pace. Women, when they hit menopause, it's like that. I mean, they just plummet. It's brutal. Menopause is brutal, right? I'm not looking forward to my wife going through menopause.
How
I'm sure she's not
early?
either.
How early can you get menopause?
Technically, you can get it at 30.
Really?
Yeah, I mean,
My mom's freaking out.
menopause, I mean, don't get me wrong. When you run out of eggs, you're in menopause. It's really that simple, right? There is no ifs, ands, or buts. So the big question is, how many eggs did you have when you were born? And how many of those eggs were still viable when you started puberty? Because here's the thing, you were born with a couple million eggs, right? By the time you got to your first period, 20, 30,000 of them were left, right? Maybe a couple hundred, maybe 100,000 were left. Most of them you'll never benefit from, right? Then every single month, depending on the regularity of your period, how your ovaries secreted them or ovulated those eggs, how well you took care of your body, how functional your ovaries are, there's so many different factors that run into it. Again, the female reproductive system is crazy complex. So how quickly you deplete those eggs, do you have an ovarian tumor, right, which ultimately takes one of them out of the equation, right? There's so many different things that go into it. But once you run out, that's it, that's menopause. The game's over with regards to you having children, right? So, and with it comes a significant drop in your production of estrogen. It's just the way it is. Now, for most women, if you're gonna go by the textbook normal, it's gonna happen somewhere between 45 and 55. But for every woman, it's different. I mean, I've met women who it happened in their 40s. There was a woman not that long ago who was like 56 years old and had a kid, right? She was somewhere in the Philippines, Thailand, you know, that neck of the woods. She had a kid, so 56. I mean, who'd have thought? Right? Damn is right. The last thing you need at 56 is an infant. And if you have an infant, it better be a grandbaby. Right? The only infants I want at 56 are grandkids that I can spoil. Someone else have a question?
Oh, well, I was gonna ask if you can still get a period during menopause.
While you're going through menopause,
Yeah.
yes, but they're going to become less and less frequent. So
Okay.
instead of, and again, I'm talking textbook here, so don't hit me with the I'm this, I'm that. Textbook is every month you have your period,
Right.
right? As you start going through menopause, you'll start skipping months,
Oh, okay.
right? But once you hit menopause, periods are over.
Yay.
Your period, your menstrual cycle is directly linked to your ovaries secreting or ovulating an egg, right? The only reason why you have a period is because the month before, the 28-day period prior to the starting of that period, you didn't become pregnant. And what your body's doing is flushing out the inner lining of your uterus, which is where that fertilized egg would have implanted itself. You're flushing out the inner lining of the uterus, called the endometrium, so that you can rebuild it again as you're now trying to, you're about to ovulate an egg. So when you think about a feminine cycle, it's a 28-day cycle. Days 1 through 5 are your menstruation days, right? Then on day 6, what's happening is your uterus starts to rebuild the endometrium, and your ovaries taking an immature egg and turning it into a viable mature egg. On day 14, again textbook, you ovulate that egg. That egg now starts to travel from the ovary through the fallopian tube towards the uterus. In that period of time that it's floating through the fallopian tube is when, if you're trying to become pregnant, is when you want sperm to be coming the other way. So the two meet and we get a fertilized egg. If that egg gets fertilized, you're going to use the uterus as the implantation site, and the inner lining of the uterus is actually what feeds that zygote for, 6 weeks, 8 weeks, until such a time as the yolk sac and the umbilical cord and all that connect to the baby, right? Well, if you don't get pregnant, there's no need to have all this building up of the uterus. So you flush it, and that's menstruation. So if you're not ovulating an egg, there's no reason for you to be flushing out the inner lining of your uterus. So as one goes away, the other one does too. So I guess if we're gonna talk about some good things about being in menopause, is menstruation is no longer a thing.
Well, my mom complains about hot flashes. That's why I asked that question.
That's a different animal. And that's the one thing I'm most not looking forward to. My wife and I already disagree on what temperature the house should be, right? And because I'm a happy wife, happy life kind of a fella, we tend to live in her temperature, and you can't keep potato salad at that temperature all the time, right? It's not good. But yeah, hot flashes are a different animal. That has nothing to do with menstruation and all that stuff.
Oh, okay.
Yeah, that's one where like you're freezing 1 minute, and then 5 minutes later you're sweating nuggets. It's nuts, right? No bueno. I'm not looking forward to any of that. Nor is my wife, I don't think. All right. Perfect. Good time. So, in lab today, we're going to keep plugging along